Welcome to KidzDocTalk with Dr. Jennie. Dr. Jennie is a board-certified pediatrician and is the Director of Telemedicine at Pediatric Associates.
Welcome to KidzDocTalk with Dr. Jennie. Today, I talk with Dr. Oleg Kovalenko about postural orthostatic tachycardia syndrome, or POTS. Dr. Kovalenko is a board-certified physician at Pediatric Associates Miami Lakes East Cardiology Department. He grew up and completed medical school in Ukraine and completed his pediatric residency at the West Virginia University Charleston Division. He completed his Pediatric Cardiology Fellowships at Rainbow Babies Children's Hospital in Cleveland, Ohio, and the CS Mott and Children's Hospital in Ann Arbor, Michigan. Dr. Kovalenko is fluent in English, Russian, and Ukrainian, and his clinical interests include arrhythmias, sudden cardiac death prevention, and fetal cardiology. Welcome, Dr. Kovalenko.
Hi, Dr. Kovalenko. Welcome.
Thank you. Great to be here.
I have wanted to talk about POTS. Actually, for a really long time, it's always been almost like a confusing and frustrating diagnosis for me as a general pediatrician to have some patients with. So I've always wanted to talk to somebody who really takes care of these patients in a more comprehensive way. So first, let's take a step back. What is POTS? What does it stand for? What does it mean?
POTS actually stands for Postural Orthostatic Tachycardia Syndrome. And it's been around for a while. It probably first time was mentioned maybe like in 40s, but never became official like a syndrome. But I think more like in late 80s, that's where we kind of like make this diagnosis, come up with criteria, and in adults primarily. But then again, about 15 years ago, it's become, an official diagnosis in pediatric population as well.
And so how does it affect children?
POTS affects children and adults in multiple ways. And so as diagnosis implies, it says postural tachycardia. So meaning, primarily when what happens when kids or somebody just standing up from sitting or laying position, you have a feeling of tachycardia. Your heart beats very fast. And so primarily that was the main criteria, but as time goes, we realize that this is not just one symptom. This is a constellation of symptoms, and the tachycardia is one, but it also affects, you develop dizziness, abdominal symptoms, such as like abdominal pain, nausea. You frequently feel fatigued and tired and cannot basically cope with the daily, routine. And very kind of devastating can be in some cases. And particular, it's kind of interesting because it typically affects children who were like a high achieving children, very athletic, very active, having a very active lifestyle. And suddenly they come down with this kind of problem, which initially felt like it's probably like they're coming down with some kind of disease like mononucleosis or something else, but to their surprise, the disease doesn't go away and kind of symptoms stay and sometimes get even worse over time. So this is just like that.
So the symptoms seem very vague. With the patients that I've seen with POTS have come to me with that diagnosis. So I was never the one to give them that diagnosis. How do you identify it? Because I feel like if I saw a child with all of the things that you described, I would absolutely go to something like mono, maybe now, long COVID or sequela of COVID, sequela of a prior virus. I would not be thinking POTS or anything in the cardiac world.
Sure. My primary specialty is cardiology and also arrhythmia. And because I saw a lot of patients with arrhythmia, very frequently I would have kids, of course, who come with palpitations. And palpitations can be anything from very benign, normal heart increase, the child is panic or worried or, any other situation, to something real like arrhythmia, like tachycardia, like SVT, ventricular tachycardia. So because of that, I saw many patients who came primarily with palpitations, of course, initially. And you're right. So initially, it's not frequently it's something you diagnose them right away. So it may take some time, like at least a couple of visits, because you know, if somebody comes and says, oh, I have palpitations primarily, then of course you have to do walk up, you know, make sure it's not arrhythmia. You do maybe EKG, you do ultrasound, you do a monitor, like a Holter monitor, and then you see in the patient having primarily sinus tachycardia, you know, and but of course on further questioning, the people have very specific kind of like, it's almost, they can pinpoint the times they, you know, the days they get sick, and they say, oh, suddenly, you know, I got all this tired all the time. I cannot cope with my routine. I was an athlete, so I cannot run without stopping now and having shortness of breath. And that's when you're going to start to realize the possibility when there's multiple different symptoms which seem to involve kind of different system in your body. But that's when you feel like, okay, so it's, you know, it's too many symptoms for to be one just simple condition. So that's when you're going to start to think it's maybe that's POTS, or, you know, because or maybe like some other type of dysautonomia, because dysautonomia, this is a big term for dysfunctional autonomic nervous system, or, you know, autonomic means involuntary nervous system, with the one we don't control. And this is, you know, something that controls your heart rate, your breathing and stuff. And so dysautonomia, it's a big term, but so POTS is we all believe is a subtype of this. So that's when, you know, you first think about probably it's like, you know, maybe it's a dysautonomia, and eventually you come to be more specific and seeing that this is mostly like POTS, and, you know, primarily by checking the child for baseline POTS symptoms, you know, which are frequently, you know, we measure blood pressure and heart rate when child is sitting, then laying down, then standing up. We comparing those numbers, and, you know, frequently heart rate can increase up 35 to 40 beats per minute from just, you know, standing up, from sitting position, laying position, and blood pressure may drop up to like 20 systolic 20 units. And that's when you know that you probably need to do more specific evaluation for POTS particularly.
So it almost seems like a diagnosis of exclusion. I say that with hesitation because it sounds like there's also very strict clinical criteria. So it's not that you did a whole workup, everything's normal, and we call it POTS. That's not what this is. There's actually some dysfunction or some abnormalities that happen as a result of the workup, or that you discover, right, during the workup.
Yeah, exactly. Because again, in arrhythmia, except as an arrhythmia doctor, first, you know, anytime child mentions palpitations or something, you go to your, you know, your diagnosis of arrhythmia, and you have to go from the higher possibility of that diagnosis, which may need like very particular medication, procedures like surgeries, and you're stepping down, ruling out one by one, you know, conditions.
So that makes sense, and why sometimes it may take a little bit of time to get to this diagnosis, because part of the workup is ruling out the other things that might be causing these symptoms. So I can absolutely understand that feeling frustrating, both for us as the clinicians, right, and the family, and certainly the child. You mentioned you see this in high achieving children, which I think is an interesting risk factor. I don't know that I've ever seen POTS in a male patient, so I'm inclined to say that being female is probably a risk factor. What are other things or other like similarities that you see in these patients?
Yeah, so it's right, because the majority of patients, actually all these people usually divided in like with two big groups, like those female primarily like 30 to 50 years old, is kind of adult type, and teenager type usually is like 14 to 19. And girls, absolutely, you're right, because we see more girls than boys, but we still see boys, you know, with this condition. And yeah, there is the symptoms are very similar, and you know, you cannot really separate like too specific for girls, for boys. They just basically very similar presentation in both.
Are there any other underlying risk factors? For example, obviously, I would think structural heart disease or anything like that would would maybe predispose somebody to having POTS, but like anything else that are like objective medical history, like all, asthmatics, increased risk. I don't know, having allergies, increased risk, something like objective that we can say, these are patients that I'm going to keep a special eye on to make sure they don't develop something like POTS or other dysautonomics.
Right. So there are some conditions which we always think about POTS, but particular, for example, Ehlers-Danlos syndrome or hypermobility syndrome. So those patients, it's like so-called type 3 Ehlers-Danlos syndrome, which actually doesn't have a genetic marker. And we make diagnosis clinically. So they have hyperflexible joints and hypermobile. So in those kids, we believe it's up to 75% of kids with Ehlers-Danlos type 3 would be having POTS syndrome, or POTS symptoms. So we also identify many kids nowadays with like autoimmune disorders or all kind of autoimmune disorders. So we know that this is connective tissue disorder, autoimmune. So very likely child may develop sooner or later these symptoms. Many neurological conditions and neuropathies, which of course more probably would be addressed by neurology, but diabetes, we see kids who have, again, this kind of cause probably because of neuropathy and changes in nervous system cells. Basically, the kids also have very particular POTS symptoms.
Oh, that's interesting, and that I guess all kind of makes sense to me because they're very sort of similar types of dysfunctions in kids. So let's maybe talk a little bit about treatments, because this is where primarily I've seen a tremendous amount of frustration both in the families and the child, and for me, kind of watching it unfold and not having a lot of experience managing it. What are some available treatments? Because I feel like they sometimes span the gamut between like evidence-based and we know these are things that help patients versus like we're just sort of desperate and really help trying to find something that's going to improve somebody's function that maybe we don't have a lot of evidence for.
Yeah, sure. The treatment is evolving, of course, and it's frequently there's two aspects, so medical and non-medical. And like many people believe that it's you have a disease, you have to have a medicine, like a medication, and we do have it. But in this particular situation, there is very strong evidence that non-medical treatment also helps, of course, together with medical. So I wanted just to touch briefly on what the mechanism of POTS, so it will make more sense.
Yeah.
So basically, anytime anybody stands up, by gravity, blood is pulled to the lower half of the body, and so during this moment, what happens? Brain doesn't get enough oxygen or blood flow or oxygen for a brief moment, and immediate response is to produce adrenaline, which will fix this problem in hyperperfusion and increase blood flow to the brain and to your body. And so as soon as it happens, so adrenaline produced, and in this particular moment, people start to feel tachycardia, the heart rate, of course, response to adrenaline increases. Then you may have like panic-like symptoms because tremulous, nervousness, lack of air. They feel like almost like a panic attack. And so basically, all the treatment is directed to try to correct this hypothetical mechanism, which we believe is true at this point. And so non-medical treatment frequently includes any maneuvers. First of all, we teach kids to avoid something that triggers their symptoms. And this is the first baseline. So for example, kids have to avoid, standing for a long time, spending time on the heat for a long time, and overheating, dehydration. They have to avoid dehydration. At the same time, they have to avoid drinking soda, coffee, or caffeinated drinks, because they stimulate urination, and you get dehydrated before you even realize it. So you're dehydrated, and So this is the second kind of way we can help. We educate kids because frequently it's a stimulus for this is prolonged sitting or standing. So what we recommend them, anytime you sitting for a long time, you have to do some exercise in your legs, for example, to make blood move. So to make the muscle contract in a leg, so it kind of stimulates blood flow from lower part of the body to upper. And they can do like flexing or flexing, for like your feet or crossing your legs, and any type of movement they can come up with, when they sitting. Then the next big portion of this, we developed the particular exercise program for kids, which can help because in POTS, in children with POTS, the last thing they thinking about usually is doing exercise, which paradoxically, this is how your body feel, but really to overcome this problem, you have to get your body to move. And if some children do not tolerate vertical, most of them don't tolerate vertical exercise or like running, walking, jogging. So we usually can introduce so-called horizontal exercise. They can do exercise when they laying on the yoga mat, and for example, do different types of exercise. There is swimming is a great sport which you relatively do. You do horizontal, and rowing. Those are particular sports which are in a list of exercise which can really, be very effective. And so we try this kind of program for weeks or months, depending on child condition. And then, of course, the next big step would be consider medication therapy. And of course, this is provided that the kids already have a specific fluids drinking program, so they have particular amounts, they follow in the rules, they eat in some salt, and it's still with exercise still is not working. So then we move on to the medical treatment. And the most common medications which we use nowadays are, I would say, big three groups. The first one was fludrocortisone or Florinef. So this is a hormone which basically increases the reabsorption of sodium, and basically retaining fluid and trying to keep your body well hydrated this way. The second, more specific, the next two actually more specific and more successful medications, which are midodrine, which alpha receptor stimulating agent, and the beta blocker. So midodrine actually acting by increasing, working on alpha receptors, so-called. So alpha receptor stimulation causes vascular constriction, and in this way we can kind of increase blood pressure, particular baseline, like increases vascular tone and helps to deal with prevent hypotension and symptoms like that. Midodrine usually has to be taken 2 to 3 times a day, and that's sometimes may lead to some non-compliance, and occasionally some may cause some problems like a little bit high blood pressure elevation with higher doses. But the good news, we never start from higher dose. We usually start from very small and 2.5 milligrams 3 times a day and move up and see how it works. And finally, beta blockers, of course, also very effective, and many people believe that this is the most effective medication in POTS, particularly such big institutions like Mayo Clinic and many other big research institutions recommend it as a first-line treatment. And of course, occasionally when you talk to doctors about beta blockers and POTS, people understand that the beta blocker may help to decrease the tachycardia component, but at the same time, it's some people may feel like, okay, when your body is coping with when you stood up and your blood pressure dropped, and one way to keep your blood flow to the brain and other systems is to increase your heart rate to compensate. So people believe that if you do a beta blocker and you eliminate that compensation, people may be like more dizzy and even faint, which is true. Occasionally it may be the case, but we recently found out that particularly, we divide beta blockers in selective and non-selective, and those non-selective beta blockers like propranolol, nadolol, they activate beta 1, beta 2 receptors. And actually, when they activate in beta 2 receptors, they helping to basically increase the tone in the vasculature of the muscle tissue, and this is probably the tricky moment which we frequently, clinicians may frequently miss, that this is a part which helping to deal with using beta blocker, but you actually normalizing blood pressure, and at the same time you treat that excessive tachycardia, you blunting slightly that tachycardic response, which helps symptoms very much. So I feel like most of the clinicians who in specific dysautonomic clinics nowadays consider beta blockers as a first line of medication. And
that does seem a little counterintuitive to me initially, but I can understand now why it would be effective. I think maybe the same reasoning is used because sometimes I've seen these kids be prescribed, and I don't know if this is evidence-based at all, but prescribed IV fluids for home. And the idea probably is the same, right? You're increasing the amount of volume, and so as such, almost like increasing, I guess, vascular return and making it a little bit easier for them to, feel better.
Exactly, yeah, because hypovolemia, or same as dehydration, makes those symptoms worse. Even kids without POTS syndrome, dehydrated, have very similar symptoms. They would stand up, they are lightheaded, dizzy, and of course, this is something more easy to fix. That's why we typically recommend oral rehydration or oral hydration. And some kids, of course, cannot or refuse, or for any reason, they may not tolerate excessive fluids. So we basically end up occasionally putting an IV line or PICC line, and kids drinking whatever they can, plus whatever the left was a requirement for the day, which we come up with. They get IV.
I want to go back to the non-medical treatment that you talked about in the beginning, and you mentioned exercise and if kids can't tolerate it being up, the options that they have for being horizontal. But from what I've seen and what you've described thus far, some of the symptoms of POTS are just general deconditioning and fatigue. And I find that these kids have a tremendous challenge, sometimes just doing basic tasks. I can't imagine the amount of effort it's going to take for them to, do exercising in a yoga mat or even get into the pool. So how do you approach that?
Yeah, so exactly. And this is, as I said, there's multiple studies show that kids with POTS do much better when they do exercise of some type versus no exercise at all. And so this is exactly what your body tells. This is the last thing you want to do with that feeling that's just to get up and go and do sport or exercise. But so this is the key. We talk to kids a lot about first of all, reasoning. You have to explain why is that and what exactly we want to achieve. And of course, in a way, you have to convince the person that, we know that this is definitely how you feel, but multiple examples show that if even minimal exercise, like even flexing, your feet or crossing your legs, or those will be still better than doing non-sports and non-exercise. That's why it's kind of like many kids, because primarily, of course, we deal with kids. You see that they understand and responsive and willing to try and get even optimistic when they realize, because for many, they feel like they've been struggling with these symptoms for too long, and many kids believe that this is just going to be for the rest of their life, and that's it, how they're going to live. But here, that's where we can explain a lot and tell them that exactly this is not exactly correct, because we definitely can improve in most of the kids, modify the disease, improve symptoms, and they can return to daily life close to normal or even normal. And then when kids realize that this is not like they're not doomed to the disease, they have a chance. So many respond to our program, which we come up. It's a very individual approach, of course, and you see in this somebody who would not tolerate, of course, vertical exercise or stuff like that. So it's individual approach, and in particular, we discuss it with particular kid, and again, reason how and why, and start from the minimum. And very soon, many kids realize that very minimum already effective, and they feel better. And again, the idea is to keep the blood moving, from moving it from stasis or muscle contraction, in the lower extremities and in whole your body, and increase in muscle tone, and it tends to help. And it takes, of course, some time, maybe like for somebody it may be a couple months, for somebody it could be 3 to 4, but we start from the very simple, and then as progressing, we kind of like recommend more and more, and for some vertical and exercise and stuff like that.
So I think that's a good segue to my last question, which is like, what's the prognosis? Because again, the limited small sample size that I've seen of children with this diagnosis, it almost feels like it's forever. But what I'm hearing you say is absolutely not, right? There's a light at the end of the tunnel. It's just sort of that could be a slow process.
Exactly. And again, as I mentioned, this we come up, the diagnosis POTS was formulated probably about 15, 20, 25 years ago. So only recently we started to have particular specific programs and more understanding. And because even when I was in medical school, we would frequently talk like, POTS is something not real, something just like that. Mm-hmm. But then it took some time for us in education to realize that this is true condition, that this is even like, for most of clinicians, it was very important to realize and that this is true condition, and we need more research, we need more resources. And so I would say maybe at least last 10 years or so, there have been the researches going on, and frequently observational studies, because we watch the kids, how they do, and giving them questionnaires, and see what treatments they get and how they feel. And so this is our base for this a decade probably of truly meaningful research and observation. And so based on these studies, we see that many kids improve, and very quickly. So at the same time, some kids say, I improved initially very much, but then in a few months, I came back not to as severe symptoms, but still something happening. And then you have to change gears and kind of adjust and move on. But we believe that this is definitely can be modified disease, and become from debilitating disease to somebody who learned to manage this condition, who learned how to adjust to this and move on with this, meaning that they definitely feeling better, and many of their symptoms improve, if not resolved. And so we do believe that this is again condition which require persistence. The people, they have not to give up, and they have to believe that there is a light in the end of the tunnel. Because interestingly, most of the POTS, we don't think it's congenital, for example. People don't think so, because symptoms can tend to show up at some point, and many kids can tell I just remember even month when I got sick. And this means that it came at some point, and hopefully it's not having that genetic genetic mechanism which continues and leads you to everlasting battle. But it's still probably we will be able to overcome this and change the course in most of the kids, and return them to normal, close to normal, or normal even lifestyles.
That's optimistic and promising. So I like this approach, and it sounds like I think there's still a lot for us to learn about dysautonomia in general. I think it's just early on in the field and it's evolving, and I'm curious to see what new treatments and therapies people will come up with in the next few years, because I think it's going to be important for us to do a better job of recognizing these kids earlier.
Definitely. And so the next step is as we go, so we're doing multiple kind of like researches in multiple like directions, from diagnosis to treatment and outcomes, and so the many researchers now aimed to see if there's a genetic component, and if it is genetic component, how it's going to affect, how long, why it's activating later. Then the other researchers, of course, we still don't know the mechanism, exactly the way we would like to. And so at this point, you have multiple symptoms, which we try to explain by that some mechanism, but still it makes sense for most, but not for everything, So medicine is a field, again, ever evolving field, and we definitely need to spend more time, more resources, and because we have all this in place, there's like many research projects, many autonomia centers, and more clinicians understanding this disease, and they refer patients in timely manner. They much quicker now to realize, this is not just something, this is just probably a POTS syndrome, and you have to address it as soon as possible. And so as we go, I believe like even in 5-10 years, there'll be tremendous change in this approach and treatment and outcome, in this difficult condition, I should say.
Absolutely. So yes, I was going to say it's a good place for us to end. Certainly very frustrating, can be a debilitating disease, but I think I'm very hopeful and optimistic after hearing all the advancements and research that we're expecting to come out in the field in really like the next few years.
Sure.
Okay,
exactly.
Fantastic. Well, thank you so much. I want to thank you so much for your time and for discussing this fascinating and frustrating topic with me.
Thank you. A pleasure. Thanks.
Make sure you like us on Facebook and follow us on Instagram and Twitter. Thank you for joining us on KidzDocTalk.